So we've done that, all the assessment now with the patient, and we found that L5 nerve is most sensitized. So you got slump test positive, you got your Australia Grace test positive, you got also hypologesic response on peroneal nerve, or maybe an tibial nerve, maybe both, yeah? So let's say he was positive at this point, yeah, so we can just go short of that a little bit and flex the knee. So we don't want any tension on the neural tissue. We want to be in quite relaxed manner. Now, other thing you could do, if it's got a lot of adduction, put the pillow between the legs, so it's less adduction. So what we're gonna do, the first thing we're gonna mobilize is the spine. So it's that sort of like a lateral glide technique. The spine is here, just gonna show you what I'm doing. Thank you. So if it's L4-5, I'm gonna block L4 spinous process from the top, and it's almost, it looks like it's an opening up technique, so it's sort of like lateral glide technique. But it's really trying to promote anti-inflammatory effect through the spinal area. And we do that for around 1 minute, this technique. After that, you saw in the video of Toby, there's slider through the leg. And also around 1 minute, 40 seconds, 45 seconds. And so the spinal mobilization plus leg mobilization would be 1 set. On day 1, we do 5 sets of this, and we do not progress. If they're happy, they're comfortable, but yeah, so even when we reassess, we've got a bit more range, we leave it like this. The next time he comes in, after a couple of days or so, then you can progress again, do neurological examination, and then, yeah. So what I do, just come closer towards me, good. A little bit less, just a bit, that's it, perfect. So you find L4-5 spinous process. So you see in a gap. Now I come on L4 and I block L4 from the top. Now my body comes on top of a patient, and all I'm doing is sort of a gliding technique through, and he doesn't have much of that, yes. So we might even put a bit of a towel, might be a bit more comfortable. If it's a patient a bit bony, so you don't want to kind of put too much pressure. And that's what I do. I use my body to create that lateral glide technique. Not my shoulder. There's going to be lots of pressure on your shoulder. I use my body to create that. So that's, and we do that for around 1 minute. Retain that, and just gliding through that spine. After that, then I'll take the leg and I go through full range of hip flexion available and return back to that position. But again, knee is soft and no dorsiflexion, so we don't want to put any tension. Remember the difference between the tensioners and sliders. The tensioners seem to increase intranural pressure, and also they may have ectopic firing of the neural tissue, and this one doesn't do that. It doesn't increase intranural pressure, so that's where it's a slider and glider. Again, we do that for around 40-50 seconds. Then we put the patient back on the bed a bit, good.
Purely passive.
Passive. This one initially is passive.
If the pain triggers, then do we stop?
Look, unless it's really big pain, I say, look, it's a bit uncomfortable, that's okay. But if that really increases your pain, then I need to look at some maybe alternative positions or so. Good. Again, I do another one. So we do 5 sets of that. So this and the leg would be 1 set. We do 5 sets on day 1 in a clinic. And then we'll just bring it back. Okay, so we do that for around 1 minute. Now let's say a patient comes back, 3 days later, maybe he's got a bit more range before the pain onset in terms of Australia Grace or slump. So then we can just a little bit on the bed, so then we can maybe change the angle a bit more through here, okay? Change the hip angle, but then again do the same thing. So go through the spine. And then when you do your slider, you don't have to go back here. You can sort of move and change the angle a little bit. So you're progressing that. But you see that I'm again shifting my weight, you relax completely, let me do all the way. So it's completely relaxed. Okay, so we do that and change the angle a bit. Again, 5 sets as well. And we continue. I said, look, it might, like I said, take a couple months, you know, or maybe a bit longer. In some cases, a bit less. When they control it, of course, we can do exercise as well. But initial exercise in that acute state, we get to lie down on the back for me. So let's say this was the leg that's painful. I get you to bend the knee, you know, hold your both legs. So the knee is completely now soft, so we don't want any tension in neural tissue. And all he can do is just bring the knee towards and then relax. It's kind of like a bit of a mobilization through that neural tissue without any tension. Okay, so keep going, yeah. So we'll do that around 10 times. Not 10 times, sorry, 20 times. A couple of sets in the morning, a couple of sets in the afternoon. As the patient gets a bit better, then we can change a bit of an angle. Now go to that again. A couple of sets in the morning.
90.
Yeah, almost. But then again, it gets better even more. Doing the same thing. Okay. Now, as a progression, maybe I will show. You can stand up, so I'll show that. So, as a progression, what you could do, then you could one leg here, but the painful is on the bed, and still keep the knee slightly soft, so it's no tension in your tissue. But then you can mobilize through the spine. So that's also the slider using my lumbar flexion, but relaxation in the neural tissue in the lower limb. Okay. So again, 2 sets of 20, 3 sets of 20, and then a few times a day as well. Okay. As the patient gets even more better, then what you could do, you can do a bit of a slump, but slider. So we're going to go, as I'm going to flexion, I'm doing knee flexion. As I'm going extension, I do that. So that would be also a slider for sciatic nerve. Can you see that? Yeah? So it's no tensioner, it's more a slider. Again, you can do 3 sets of 20 or 2 sets of 20 twice a day, around that. But certainly when the patient, it depends on where they need to go, on their function. Also land-based exercises, depending what you find in terms of, you know, if you've got some muscle reduction. Also make sure you give them a good education. So you're not always dominant and standing on the side. Because some people get into the habit, shifting away from pain. It's okay to do that for a couple of weeks, but as the pain allows you, you kind of want to become a bit more symmetrical. When you're standing, when you're walking, when you're cooking, whatever you're doing. And then you can start doing just nothing necessarily specific. You can do some squats, lunges, cardiovascular things as well. So it's not really boring just doing this kind of thing as well. So depending on what they need, but make sure that they do not go into that maladaptive behavior. In that maladaptive behavior, then they really become very dominant on an affected side and literally ignoring that side. And that's true not only for back-related leg pain, but also some of our acute pain with a shift. When they then start really changing behavior, scared to load because the minute load is painful. So pain, association with more damage, some going away. Pain, more damage, going away. So fear is a big factor why we're not loading the leg. But it's okay in acute setting. But if you're 3 months later doing the same thing, certainly it's not helpful for the patient to recover. And you can have secondary changes, muscle imbalances, weakness on the side, and also then more sensitivity when you try to load. So it's a counterproductive. So I think then create that symmetry between right and left. Okay, so that was for sciatic nerve. For femoral nerve, we do the same thing. So let's say it's L3 PNS, you block L2, so the glide would be the same, but then the mobilization, so you lie down, face that way. I'm just going to show you that kind of mobilization. So for the femoral nerve, so this one would be the same, yeah, in a spine. The only thing, what I need to do, I need to stand behind the patient a bit more. And then, yeah, we can bring the leg a bit more here. And then initially what I do, place the hand under the knee, and then you slide back. So that would be more for femoral nerve C, so behind the patient. So we do again for around a minute. So just going to that kind of neural slider. As they get better, maybe a bit more knee flexion. Okay, and as they get better, even more knee flexion. So almost becomes more like a tensioner. Again, less common clinically that you will see this for L3. But you know, some athletes we have cork in a quads. You know, we have a kick. You know, we play soccer or whatever, and they have like an injury, like a cork in hamstring. So you can have intramuscular bleeding, and you can have nerve sensitization secondary to the muscle bleed, including for hamstring tears as well. And people say, oh look, you know, got this pain, but probably because also you get some inflammation in sciatic nerve. So some sliders could be also part of even in acute sort of muscle tears. You know. Okay, so guys, any questions on that? Now for femoral nerve exercise, so the same thing like for active screening. So we may need to start sort of more in a sort of a hip flexion, and then we do contralateral side bending. You know, 2 to 3 sets of 20. As the patient gets better, bring the knees in line, do the same thing again, 3 sets of 20, twice a day. As you get even better, then almost can become a slight tensioner. But again, not because of tightness, but not because of pain. There is pain, so keep it in a position where they are comfortable. All right. Any questions, guys, from this?
I want to ask if a patient has worsening in symptoms during or after doing the home exercise. So
If it was, sorry?
if a patient has worsening in symptoms after
Symptoms of in pain.
the pain maybe during or after doing the home exercise, so how will you handle with this?
So I've always, before I give them exercise,
Mhm.
I look at if they can do that in a clinic,
Mhm.
and then does it increase their symptoms? You know, and then I find a position that they're comfortable with. But also, another suggestion would be don't give them too many exercises. Just maybe one, do 2 sets of 10 to 15, and I say to them, monitor your 24 hours. So if the next day when you wake up, it's not worse, maybe it's not completely better, but it's not worse, that means this amount of repetitions is okay for you. So continue that for a week, and then if there's no any kind of flare-ups, maybe next week increase by 10%. And then you can never flare the patient up, and that's a similar way how we expose patients with chronic persistent pain. With the back pain, I think, with the neck pain. So the exercise will progress sort of 10% each week if there's no flare-up. But warn them, look, because we move things around, you might have a bit of post-treatment soreness. So when they wake up, they don't get so freaked out, oh, physio did something worse for me. But that's why education about pain is so important. You say what kind of pain they have. You've got inflammation. So inflammatory pain, usually you may have pain more at night. In the morning might feel a bit worse because you haven't moved your body. So everything is sort of almost in stasis. So that mobility, motion is lotion. So all about communication. Pre-warn them. Make sure they don't freak out when they wake up and suddenly is in more pain.
What will be the contraindication and red flag that you will look for before we start this?
So you tell me. We discussed that. What is the contraindications for any manual therapy in a spine? Infection. What else? Yeah, maybe got some oncology, maybe got metastasis in the spine, and cord equina. Because we screen at the beginning, isn't it? So make sure that they don't have any of those, and then. Okay. Yeah.
If someone comes in the first session and has a lot of shifting, so do you treat the shift first, and then you can go on to all these things?
Yes. And you know, some people cannot lie down on the back as well, or on the stomach because they can't get up. So if they come in like this with acute back pain, we start. And it's going to be painful. So guys, don't be afraid of pain. Pain is because of inflammation. So you've got inflammatory response going on. So you said, look, I'm sorry, it might be a bit uncomfortable because this is inflammation, but let kind of just start motion is lotion. And then show home exercise, and then taping. Taping, give them good advice. So read about education so they're not frightened. Because the more they, the less they understand about their problem, the more threat they feel. the more threat they feel, the more pain often they feel as well. So that's why this education is so important, and I think that pain and understanding about pain a little bit, that's also quite important as well. Okay guys, so let's try then a bit of a gliding, and then with the leg for femoral and sciatic nerve. Okay.